Hello there, I'm going to talk about translational research for McArdle disease. I guess as somebody with the condition, when you think about research, what you want to see is the development of a drug that's going to improve your symptoms and improve your quality of life. And I think it's important to understand that the drug pipeline from early development, which is laboratory-based research, to actually a drug being licensed and available and funded takes about 10 to 20 years. In the UK, our regulatory bodies include the MHRA, the CHMP, NICE, and then NHS England, and they all have to approve a new drug before it's licensed and funded. And each country has its own regulatory processes, but they're all pretty similar. So clinical trial development really is a great example of translational research because it begins in the laboratory and it ends at the bedside. In the laboratory, preclinical studies are really important to look at disease processes to help us understand why the condition occurs, to understand its underlying cause. So, for example, in McArdle disease, it would be looking for the genetic cause, looking for the missing enzyme, which we now know is glycogen phosphorylase in muscle tissue, and then looking for any other secondary disease processes. In the laboratory, you can then also test potential treatments against tissue cultures, and also you can trial treatments in animals. Once this stage of preclinical research has completed, which may take many years, the drug can then be tested in healthy human subjects. These we call phase 1 safety studies, and they usually only require a small number of people to be tested, and these trial studies last only for a few weeks. The second stage in clinical trial development are phase 2 studies. These involve a larger number of individuals. They will involve a placebo-controlled design. This is where a placebo or a dummy drug is compared with the active substance to see that whether or not the active substance is having an effect. These studies will also look at safety. Usually these studies will last for 6 months or 12 months. Finally, phase 3 studies may also include a placebo-controlled trial in a larger number of patients, again looking for safety, again looking for efficacy, and also these studies may continue for many years with an open label component, again looking for safety. All trials are very heavily regulated these days, and this is to ensure patient safety. So every trial has a protocol. A protocol is a legal document that has to be strictly adhered to. This document has to be approved by an ethics committee to ensure that the research is ethically sound, and also by hospital R&D departments, research and development departments, to ensure that the trial is safe and that patients will not be put at risk, and also by one of the regulatory bodies, the MHRA, again to ensure patient safety. A sponsor is an organisation that is responsible for the conduct of the trial to ensure that there are strict standards and that the trial is conducted properly. So a sponsor could be a university, it could be a teaching hospital, or it could be a pharmaceutical company. One of the things that is also very important for sponsors is that they must properly disseminate the results of the trial. And there is a website called clinicaltrials.gov where we have a legal obligation to report results of all clinical trials. During a clinical trial, there may be multiple sites. So there may be multiple hospitals, for example, involved in a clinical trial, and each site is carefully monitored by the sponsor. This monitoring process may occur every 6 weeks, where all of the notes and records of trial participants are very carefully read through by a monitor to ensure that the trial has been conducted properly and safely. For people who want to go into a clinical trial, before they can be recruited, they have to be assessed to see if they comply with the inclusion and exclusion criteria that have been laid out in the trial protocol. This requires a screening visit, a pre-trial visit, and there'll usually be a checklist to go through to make sure that the individual is eligible to enter the trial. This is very important. Firstly, it's important we have people entering the trial who have the correct diagnosis and who fulfill the correct entry criteria. And secondly, that people who have underlying conditions that might cause them harm if they were to take the medication are excluded from the trial. An example of this would be a pregnant woman where an unborn fetus might potentially be harmed by a novel drug treatment. Once the individual has been shown to be eligible to participate in the trial, they will be given an information leaflet which outlines in detail what is required from them as a participant, but also what the trial will mean for them. In other words, how many visits they will require, how many blood tests, what are the potential risks of entering this trial, how will the trial affect them. The patient should be given adequate time to read it, and that may mean taking it home and looking at it at home. And they may have questions that they wish to ask before finally agreeing to participate. If the patient agrees to participate in the trial, it's important that they fully understand all of the procedures, that you can't just agree to do the trial and then one day say, oh, I can't come today because I've got something else on. If you agree to participate in a trial, you absolutely have to attend the appointments on the days they're given. And that's because the protocol is really tight. Usually there may be only 1 or 2 days where you can vary an appointment. So really, you as an individual should not consent to participating in a clinical trial unless you're able to attend all of the visits, that you feel happy, that you're happy to go into the trial, that you're free to go into a trial, and that you haven't been coerced to enter the trial. It's also really important to understand that if you participate in a trial, you can leave it at any time, so you don't have to continue. So if we think about trial phases, going back to my previous diagram, I showed you phase 1, phase 2 and phase 3 trials. But actually another important aspect of planning clinical trials is to collect natural history data and to ensure that patients entering the trial are all at a similar level. And in addition, we need to ensure that the trial has the right outcome measures. There's no point, for example, having as an outcome measure for myocardial disease muscle strength in the legs, when in most people with myocardial disease, the strength in the legs is normal. What matters to people with myocardial disease is the discomfort they get when they exercise or do physical activity. And so the outcome measure has to really reflect how the condition impacts on people in their daily lives. And that means doing some sort of exercise test. In addition, if we're testing a new drug, we need to do safety blood tests to make sure it's not affecting liver function or kidney function or the blood count. We also need to do a physical examination to make sure it's not having any adverse effects. Another good way of assessing the effectiveness of a drug would be to take tissue samples before and after treatment. So for example, in myocardial disease, if we're wanting to replace the enzyme glycogen phosphorylase in skeletal muscle, then the ideal tissue sample would be a muscle biopsy before treatment and a muscle biopsy at the end of treatment. But of course, this is an invasive procedure, and so people need to know about this before they go into a trial, and they need to know how the muscle biopsy is going to be taken. So in terms of trial readiness, registries are a very good way of collecting natural history data. They're also a very good way of identifying participants for trials, and so they're very important for sponsors. So for example, if I were the head of a small biotech company that's found a potential drug that they want to study, then going to a trial registry organizer to say, look, I've got this drug, how many patients are on your registry, how many of them would fulfill this criteria, may be a very helpful first step. And we're very fortunate that the European Union have funded a registry called EURIMAC. So this is a secure database. It does not show individual personal information. So each person who is included in this registry has a unique identifying number, but you cannot see their names. They cannot be identified. And this is very important in research, that patients maintain their anonymity. In addition to a registry where we can look at the number of patients and how the condition affects them, it's also very important when we're planning clinical trials that any patient going into that clinical trial is receiving the same level of care no matter where they live. So actually developing standards of care are very important, and the members of the EURIMAC network, together with IAMGSD, have very recently published standards of care for myocardial disease, and this includes standards for diagnosis as well. So these standards are very important when it comes to trial readiness. Seeing patients in specialised services, I think, is also very important, so that for trial readiness, participants going into a trial have all been receiving the same standard of care. And as I've said, this is very important. So, myocardial disease, you already know this, I know. It's a rare disorder. The prevalence is probably about 1 in 170,000, although it's reported to be more common in the USA. It's caused by this absence of the enzyme muscle glycogen phosphorylase due to a mutation in the gene. And that means that all of this glycogen that's stored in muscle cannot be accessed by muscle tissue for energy when you're exercising. And the consequence of this is you cannot produce lactate. So you see from the bottom graph, the red line is someone with myocardial disease who cannot produce lactate. The blue line is somebody who does not have myocardial disease who produces lactate after 5 or 6 minutes. If we were to do a muscle biopsy, we would see in someone with myocardial disease these little blebs here. We call them vacuoles, and they're just under the muscle membrane, which is called the sarcolemma. And that's due to abnormal storage of glycogen. So this is a healthy muscle sample here. In this healthy individual, you can see that the enzyme glycogen phosphorylase is expressed and it stains purple. It's darker in type 1 fibres than it is in type 2 fibres. In the person here with myocardial disease, there is no enzyme staining except for this thin line here, which is the enzyme that's present on smooth muscle in a blood vessel. And this enzyme is the brain form, which is also found in fetuses, and it's also found in regenerating muscle tissue. We also know that there's a liver form of this enzyme, so there are 3 forms of this enzyme. But crucially, this brain form here can be expressed when muscle tissue is regenerating. So we know it's there, but it's not expressed. Again, you'll all be familiar with this. There are three main fuels that we use for exercise. We all have stored ATP, so it gives us 6 seconds worth of ATP for doing strenuous activities. And if you have myocardial disease, you can safely do these activities for 6 seconds, but then you have to wait for 30 seconds for this store of energy to be replenished. This is purely anaerobic pathway. It means it does not burn oxygen to give energy. Carbohydrate that is stored in the muscle is an intermediate pathway, and we use it for strenuous exercise, but also to rev up fat burning, which we need for aerobic exercise. So if you have myocardial disease, this is the pathway that's blocked in skeletal muscle tissue. So bearing that in mind, that gives us an idea as to what strategies might improve the symptoms of somebody with myocardial disease. So firstly, we could attempt to replace the enzyme that's missing in the skeletal muscle. Really, the only way this could be done is through a gene therapy procedure where the faulty gene is put into a virus that's attenuated, and that virus is injected into the person with myocardial disease, and the virus goes into the cells and starts producing the enzyme because it has the normal healthy gene. So there are gene therapy trials going on in other muscle conditions, particularly Duchenne muscular dystrophy, and we know that gene therapy is now licensed for another condition called spinal muscular atrophy. But gene therapy does carry risks. We know that there have been some trials where patients have died when they've been injected with a gene therapy virus. So we have to balance the benefit against the risk. And at the moment, because myocardial disease is not a life-threatening condition, the risk of gene therapy outweighs the benefit. Now, that does not mean that in the future gene therapy would become available, because I think with these early pioneering research studies, the safety of gene therapy will certainly improve. So I think this is something for the future, but it's not for now. Another alternative might be to switch on this dormant brain isoform that's already there in muscle tissue. In other words, the gene is switched off, so we need to switch it on. And there are a group of drugs that potentially could do this. These are called HDAC inhibitors. So that's an option for perhaps future research. Again, this could be done through gene therapy, but as I've said, I think at the moment this is not a feasible option. Also, another strategy would be to improve fat burning so that you don't need glycogen for those first few minutes of an activity before you get into a second wind. So if you could always be in second wind, that would have a real benefit for patients. So potentially you could improve fat metabolism through exercise by becoming your muscles becoming conditioned, or perhaps by giving a drug to improve mitochondrial function, or even through diet.